Kolkata, and Dr. Ankit Sahu from SGPGI. And I think without wasting much of time, I just hand over to Prasadit Kapoor to introduce the topic and the presenters. Straight to Prasadit Kapoor, sir.
So am I audible?
Yes, very well. Okay.
Okay, perfect.
Good evening again. So I'll be presenting a case of 31-year-old male with dyspnea and cyanosis. So is my screen visible? Thank you.
Yeah, we can hear you.
Thank you, sir. Is the screen visible, sir?
Yes, madam. Screen is also visible.
Visible, madam.
Thank you. Thank you so much. So, sorry, sir, it will be 31 years actually. So this patient, whose name I won't be exposing,
there is some...
is
Go ahead.
31 years old male. He hailed from Sundarbans, West Bengal, and the informant is the patient himself and his mother. Both are reliable. So the chief complaints are bluish discoloration of lips and fingertips and toes for 2 months of age. Few episodes of lower respiratory tract infections for 6 months since 6 months of age, squatting episodes since 4 years of age, and exertional dyspnea since adulthood. So the history of presenting complaints: bluish discoloration of lips, fingers, and toes. Child was apparently normal before 2 months of age. Then bluish discoloration of lips, fingers, and toes were noticed by the mother. Appeared when baby cried and disappeared when baby was calm and playful. At about 10 months of age, the mother noticed episodic increase in bluish discoloration along with hurried breathing while feeding and crying. These episodes were relieved by holding the child in caressing position with flexed limbs by the mother, occurred about 2 to 3 times per month, and they were not associated with convulsions or limpness. Squatting posture was first noticed by the mother, which were adopted by the child since 4 years of age. Squatting posture would be taken by the child upon exertion when he used to develop the episodes of discoloration of lips or fingertips with difficulty in breathing while running around. Then the child would adopt squatting posture for a few minutes, which would relieve the symptoms. Episodes of respiratory distress along with associated with respiratory tract infections. The child would also develop few episodes of respiratory distress, which were associated with respiratory tract infections. There was a cough with expectoration during those episodes, and they used to be relieved upon medications from the local doctor. And these episodes started since 2 months of age and continued till the child was around 7 years of age, after which they decreased in frequency and ultimately stopped. There is no complaint of chest pain or palpitations. Child started avoiding activities requiring exertion since he was about 5 years of age, like running, sports, etc. Shall I move on to the negative history?
Yes.
Thank you, sir. So negative history: there is no history of puffiness of face or decreased urine output, no history of limb swelling, no history of fever, abdominal pain, loss of consciousness, convulsions, or focal neurodeficit. There is no history of hemoptysis or chest pain. Family history: he was first born to non-consanguineously married couple, born 8 years after marriage. He was conceived naturally. There is no history of drug intake of mother during antenatal period. At the time of marriage, mother was 24 years old and father was 34 years old. Younger sibling is 3 years younger to him and is normal. Birth history: antenatal, he was a booked case. Mother received IFA and two doses of tetanus toxoid. Quickening was felt at 5 months. Antenatal scans were not available. No gestational diabetes, pregnancy-induced hypertension, or thyroid disorders. No, no history of drug intake during pregnancy. Natal and neonatal history: he was delivered at term by vaginal delivery. He was weighing 2.5 kgs of birth, that is low birth weight. Neonatal period was uneventful. There is no history of NICU stay. He was immunized as per national immunization schedule. Last immunized when he was 5 years of age. Developmental history: he attained age-appropriate milestones properly, dropped out of school at an early age due to financial constraints. He avoided sports, exertional activities, usually stayed at home with his mother, and helped in household chores. Socio-economic history. Father is farmer by profession, income about 10,000 per month, lower class according to modified Kupuswamy classification. So summary, 31-year-old man, first born to non-consanguineously married parents with normal birth history, apparently normal till 6 months of age, when he started developing bluish discoloration of fingertips and nails while crying and feeding, static till 10 months of age, after which there were recurrent episodes of increasing bluishness associated with hurried breathing, preceded by crying. He also had few episodes of lower respiratory tract infections. Over the years, these episodes has been replaced by adoption of squatting posture by the child. Exertional dyspnea, however, persisted into his adult life. General examination.
No, just,
No, like we'll stop
just a
here.
minute. Just a minute.
Yes, sir.
Can you go back?
Yeah. Dr. Devdutta, it's quite a detailed history presentation. But a few things are that I would like to clarify before we start analyzing the history.
Yes.
So one is you said episodes of LRTI.
Yes,
How are
sir.
you sure that these are all LRTI, not URI? Like, does the child required hospitalization anytime?
There is one history of one episode of hospitalization when he was very small, about 4 months of age. But after that, he used to go to the local physician and would be treated by the medicines over there. And he used
So suppose if the patients remember so many things, so how long he was hospitalized? Was it severe pneumonia or what was the kind of pneumonia? That is number one, you should elaborate. Number two, patient can have few episodes of LRTA or URI, but where they associated with symptoms of heart failure, like, so what are the symptoms of heart failure in the infant that you will look for?
So puffiness of face, swelling of entire body, decreased.
So those are very rare. No? Like, what are the most common symptoms infant will present with heart failure?
Present with failure to thrive and
Yes.
failure to feed.
Yeah. So sweating in the forehead while feeding, sucrose cycle. So all those things are must if the patient has recurrent LRI symptoms being told very clearly.
Yes, sir.
Since the patients are able to recollect 30-year-old story, you have to take it with a pinch of salt. So some of them may not remember like episode of hospitalization, how long he was hospitalized and all those things. But LRI should be associated with symptoms of heart failure at the time. Were they associated with heart failure?
Sir, from history, it is not apparent since it was long back and the patient is not educated enough to remember that.
Is the mother absolutely sure that cyanosis started before these symptoms of LRTI?
They appeared at around the same time, but the symptoms of LRTI started a little bit earlier.
So when was the child first told to have a heart disease? So it's a 31-year-old male. So when was the child first told to have a heart disease and what was done to that evaluation?
When he had the bluish discoloration appeared, he went to the local doctor who told him that he has a heart disease, but the detailed investigations were not available.
At what age? At what age? Because that is all very important. Like,
yes, sir. So
at what age he was told to have a heart disease, diagnosed to have a heart disease?
So at around 4 years of age, he was told to have a heart disease, but the father being a farmer, he paid no attention to that, and he kept on having those.
And one more thing is, you said, what are the current symptoms like? You never elaborated on the current symptoms, like why the patient reached you right now at 31 years of age?
Sir, those symptoms of LRTI and cyanosis and spells, they were over by the age of 5 to 6 years. Then he he adjusted to low amount of physical activities and he would avoid all types of exertion and everything. But at present, he's presenting with exertional dyspnea, which is about NYHA 2 to 3 from his history.
So, but that should feature in your history as well as in the summary, like. So currently, that is very important.
Yeah, go to the summary.
Yes. Yeah. So exertional dyspnea persisted into his adult life.
But that should be your presenting complaint also. That should be there in your functional class, has to be there in your summary also. Okay. So what is the functional class the patient has to have? So, how do you interpret your history? Like, what are the possibilities?
Dr. Rama, one second, because what Dr. Rama asked, this question is extremely important for all the students who are listening. He asked specifically whether LRTI was associated with symptoms of heart failure. So can you just tell us why is he asking you this exact association? It will make a difference now which pathway you are going down, because he is having blueness and you said LRTI. So but the LRTI is associated with heart failure.
Yes.
You said probably not, isn't it?
Sir, probably not, but I would require detailed clinical examination to ascertain whether they were associated with the heart failure or they were plain simple episodes of LRTI.
Okay. Any of the other examiners want to ask? Dr. Ankit, Dr. Mandal, Dr. Radhakrishan is still with the audience.
History-wise, you can't say the patient had failure or not. Actually, Dr. Rama told that regarding the failure to thrive, sacral cycle, and other things. You see, LRTI can occur even in symptomatic heart disease without increased pulmonary blood flow, because symptomatic heart disease, they are having that decreased ciliary, in fact, clearance, and all other immunocompromised. They can have LRTI.
Yes.
But whether they had associated heart failure is important.
Yes.
Failure to thrive, sacral cycle, sweating during feeding.
So there is no history of failure to feed or sweating during feeding or the child being unable to feed, but mother is recollecting vivid episodes of the child being not able to feed because of bluishness, and he would get easily fatigued while feeding, and ultimately the overall height and weight of the child has been grossly compromised.
That means patient didn't have heart failure that time.
Probably not, yes.
Okay.
And one thing more, Dr. Rama, you said this again, very important point where Dr. Rama sir brought out. LRTI, whenever you say, you have to mention hospitalizations and perhaps also ask IV antibiotic use. And Dr. Rama, is there any definition of having a certain number of LRTIs per year? Is there any specified number that more than X number?
Any admission for a hospitalization is considered serious LRTI. Any patch that is documented by radiologically is also considered significant. But apart from that, the IAP has given age-wise definition, so they can refer to that.
Great.
Indian Association of Pediatrics has an age-wise definition.
Great.
So what is your possibilities now? Like what possibilities you are considering now?
So since the child is having definite cyanosis and history of spells from his childhood, probably he's a cyanotic congenital heart disease with decreased pulmonary blood flow. But since there may be chances of heart failure associated, so we have to keep the diagnosis of top physiology with a restrictive VSD or an absent pulmonary valve or pulmonary atresia or one with aortic regurgitation.
No. Like stop. Like I think you cannot keep the whole decreased QP for this differential diagnosis. Like so, why suppose what you're thinking is top pulmonary atresia, top with absent pulmonary valve, and top with restricted VSD. So, but why should you not keep a restrictive VSD as your first possibility? When will you keep restrictive VSD? When you think of restrictive VSD in an adult coming to you, based on history.
As based on history, he will be having right heart failure symptoms. And
so in your patient did not have any future suggestive right heart symptoms.
Sir, from history, I'm not very clear, but I'll require detailed clinical examination to ascertain that.
So because stop with restrictive VSD is such a rare entity, so you should not consider it unless there is a strong, especially at this level of history. You should consider it when there is a right heart failure, features are there. Like that means pedal facial puffiness or abdominal distension or something is there. Right hypochondral pain is there. Then you can consider that.
Yes.
But what about absent pulmonary valve? Why you should not consider absent pulmonary valve, and why you should consider in this case? What are the things against and what are the things for in this case?
Sir, in tetralogy with absent pulmonary valve, the child is usually doesn't survive up to 31 years of age, and he presents neonatally with failure, difficulty in breathing, stertorous breathing or wheezing. And since RV is grossly overloaded, like both pressure and volume overload, so he'll go into RV failure very fast. And like.
So we all have seen exceptional survivals of top substance pulmonary valve 31-year-old. It's all exceptional survivors. Even top that way is exceptional survivors. So that is okay. Like, but what is against top absent pulmonary valve in this case?
What is the biggest point which is against?
So do they have spells and squatting?
No, sir. No.
How
Because
is generally the saturation of top absent pulmonary valve by and large? They saturate roughly around 90s, 92,
Yes.
85, 88, 92, that range, not the severe swelling range. Like.
Yes, sir. They have good pulmonary blood flow, so the saturation is usually on the higher side.
So what about pulmonary atresia?
So if the patient has a large collaterals, then he would be presenting with heart failure at a very young age or neonatally. So pulmonary atresia is a possibility here. And he'll be also presenting with deep cyanosis. But if the heart failure symptoms were majority over there, then the cyanosis would develop late. But from history, both appeared at around the same time. So like 25% of the patients of pulmonary atresia presents with both symptoms. So that might be a possibility.
So what is against routine tetralogy, simple common garden tetralogy like?
Sir, against?
Anything against common garden tetralogy?
Sir, he has survived till 31 years of age. That is a...
So first possibility has to be top, like that when you're coming with cyanosis, first possibility has to be top.
Yes,
so, but
sir.
is there anything against tetralogy? What about recurrent respiratory tract infection in tetralogy?
You said recurrent respiratory, no?
Recurrent respiratory tract infection usually doesn't occur in tetralogy unless the patient is immunocompromised and
so what are the situations when you have a respiratory tract infection in tetralogy like physiology?
Sir, again, top with congenital absent pulmonary valve.
Very good. So one is top with absent pulmonary valve. Then what else?
Yes. Then sir, top with pulmonary atresia, restrictive VSD.
Why should pulmonary atresia have respiratory infection like?
So probably those were the symptoms of failure.
So those top with pulmonary atresia who have large flow, generally they are not very sinus like. So basically the flow, the amount of blood flow that goes into the lungs, definitely the saturation will improve.
Yes, sir.
So both are exclusive. Like suppose somebody cannot have a spell if it's actually overflowing.
Yes, sir.
So they can have definitely top with absent pulmonary valve, top with pulmonary atresia with large flow can have recurrent respiratory infection. Agreed. But
Yes,
they
sir.
cannot have spells like. Then what else?
So top with aortic regurgitation.
No, but they all have right heart failure, but not recurrent respiratory infection. Because restrictive VSD, top with AR, all these occurs in adolescent age group or at the end of first decade. So then generally by the time recurrent respiratory infection is not a common feature. So what other common features are, other common associations are like some congenital genetic syndromes. So for example, Downs with TOF, they can have recurrent respiratory infection. And then cardiogenic top is not a very common association.
It's not associated. No?
So then other important thing is sometimes some of the tetralogies can have tracheobronchial abnormalities, airway abnormalities. So these are the things that to be considered if the patient actually has a LRTI during this episode.
Also, pulmonary tuberculosis is often common in cough. It's a common lung infection.
So this is one thing that is slightly a deviation in your history. But apart from that, everything else looks okay. But what is the common age for spells like? Is it common like the spell comes and then later on settles?
Yes, sir. Sir,
so what is the common age of spell?
Usually they start by about 4 to 6 months of age and they are gone by the child has achieved 2 years.
Why this happens? Why they don't occur in say 1 month of age or 10 days of life? The spells don't commonly happen.
Sir, spells take time to occur because the fetal hemoglobin takes time to fall. Sorry, sir. The RVOT, the infundibulum becomes more stenosed due to more amount of fibrosis. Then the child becomes more active as he grows. And
you said infundibular stenosis progressives. So is this a progressive disease, tetralogy? What should the correct answer be?
Fibrosis of the infundibulum.
Actually, difference in SPR is there. Because as the SPR falls, the shunting from right to left increases.
Okay.
So with activity with age, SPR decreases.
So, apart from that, the child becomes more active and he could require more amount of oxygen, which will not be available by the amount of pulmonary blood flow is having.
Those are all fine, but why the spell settle by around 2 years of age?
Sir, it settles by 2 years of age because there are a few hypotheses over there. One is the progressive in growth of the stenosis of the infundibulum. It stops altogether because there is a gross fibrosis of the infundibulum. Then again, the child adopts to a posture of squatting, and he knows how to stop the spells.
Most importantly, most of the people who have severe spells are all eliminated. Either they get surgery or they are all dead.
So maturation of the respiratory center is one of the main causes.
That is also one, but most common thing is those who are spelling child, generally top tetralogy, most of them will die.
Yes, sir.
Most of the spellers will die.
So development of collaterals is another cause.
So another important thing is the squatting. Like, let's come to squatting.
Yes, sir.
So what is the mechanism of squatting? How it relieves the symptoms?
Squatting cleans up the femoral arteries, and thus it increases the SVR. So more the SVR, less will be the right to left shunt. Then squatting also disposes the prevents the deoxygenated blood from lower limbs to go up. Then it also squeezes the splanchnic and mesenteric circulation veins, which has a greater amount of oxygen, and that goes up into the circulation.
Very good. So what are squatting equivalents like?
Squatting equivalents are, sir, Nietzsche's position taken up by the mother, then the patient lying down with his legs crossed, sitting or kneeling with his legs bent in a position, legs
so
bent
many
up.
such positions also have the same hemodynamic effects like.
Yes, sir.
So can Eisenmenger have squatting?
So 10% of Eisenmenger presents with squatting.
So even though I agree that some of the literature says 10%, but it's so high. But there's a few of them may have, like few of them may have. Eisenmenger also can have. So can this be an Eisenmenger syndrome?
Sir,
the patient has LRTA, recurrent LRTA.
Yes, sir. So VSD Eisenmenger or PDA Eisenmenger or AP window will with Eisenmenger can present with.
Can this patient be Eisenmenger?
Will you consider
one answer? Possible, not at all possible, or extremely uncommon, or not possible?
Possible, sir.
Why possible?
Because
why it is not possible? I would say this is not possible.
Sir, the minimum time.
So what is the age of onset of cyanosis in this patient?
So 6 months.
2 months.
2 months, no?
Yes,
you started
yes,
at 2 months.
Yes, sir. Yes, sir. Yes,
so
sir.
2 months and Eisenmenger becomes cyanotic. So what type of Eisenmenger you are dealing with?
Sir, AP window Eisenmenger starts at a very early age, but VSD.
No, not even AP window doesn't become a cyanosis at 2 months of age. Visible cyanosis doesn't happen.
Such an early cyanosis, what type of physiology would you think?
Sir, early cyanosis, I would it's suggestive of tetralogy physiology with
no. In the
Eisenmenger syndrome.
In the Eisenmenger physiology.
So for the Eisenmenger physiology, there are a few Eisenmengers. One is the CCHT increased QP Eisenmenger. That means, for example, TGA VSD with Eisenmenger or TAPVC with Eisenmengerization or single ventricle with PH. So those kind of Eisenmengers can become very early, become very early. So like mainly the TGA, for you to remember, TGA VSD PH, for example, the patient will be blue at 2 months, and by 6 months, 1 year, the patient would have become Eisenmenger. But they will never have a longevity of 31 years. Yes. So age at onset is a very important thing that should be there. That's just 2 months. You said here you have written as 6 months, but that's a very important clue to this.
Okay.
Such an early onset. It has to be अगर आपको अगर है तो it is some admixture lesion transposition with large BFD.
सर मैडम का फोटो खूब निकल रहा है सर.
So for the sake of others, we can think of Eisenmenger as three
हमें लग
types.
रहा है कि सर
In terms
मैडम
of
आपसे
adult presentation.
आगे ही रहती.
तिवारी जी आप म्यूट कर लीजिए अपने आप को.
अरे सर बेकार आदमी.
अरे डॉक्टर तिवारी सर आप म्यूट. हाँ ठीक चलिए.
So for the sake of others, to everybody to understand, the adult Eisenmengers can be of three types. One is CCHT with increased QP Eisenmenger. That's extremely rare for adult survival. We'll talk about it the last. But the common garden variety will be two types. One is insidious onset of cyanosis at around say 18 years, 20 years of age. Never told to have a heart disease, never had an increased QP or never had a features of LRTA. That forms roughly around 40 to 50% of all Eisenmengers. And the next group is classical, that we have the prototype presentation like the patient has increased QP-like features, failure to thrive in childhood, and later on has a very quiet period in between, and now presents in adolescence with cyanosis and effort limitation. But the other third group that is extremely uncommon, which will be this one is CCHT increased QP Eisenmenger, where you have increased flow with cyanosis in early childhood. That means infancy, like truncus or TGA or DWARI, BSDPH and all those stuffs. So they become Eisenmenger very early. Their survival is very limited. Very few of them will reach 20 years of age.
Hello.
Yes, sir.
Okay.
So if you, I just have a question that if you ignore this age, 31 years.
Yes.
Okay. So if the patient is say 10 year or 15 year of age.
Yes, sir.
So what's the possibilities?
Sir, the possibilities would have been again tetralogy with tetralogy phallophysiology with decreased pulmonary blood flow.
Yeah. Okay. Okay. Go ahead.
Sir, general physical examination, anthropometry. His height is 139 centimeters, which was much lower than the 2 ST below the normal height for his age. Weight was 33 kilograms. BMI 18 kg per meter square. Head circumference was 54 centimeter. Upper segment, lower segment ratio was 0.73, which was decreased. He had low set hairline, short neck with restricted neck movement. Kyphoscoliosis was present, so he had dysmorphic facies. His mid-arm circumference was 19 centimeters. He had plethoric conjunctiva with central cyanosis, clubbing, grade 3. Pulse was 92 per minute, regular rhythm, normal volume, no radioradial or radiofemoral delay, normal condition of arterial wall. All peripheral pulses were palpable. Blood pressure was 107/72 in right upper limb and left upper limb, and 112/72 in right lower and left lower limbs. Saturation was 75 to 80% in all 4 limbs in room air. JVP was raised 7 centimeter of water above sternoclavicular angle at 45 degrees. That is 5.1 millimeters of mercury. He had prominent A and V waves. Abdominal jugular reflex was negative. Temperature was normal, surface temperature normal, no pedal edema. So on inspection, trachea appears to be central. Chest was normal in shape. Precordial bulge was seen more on the left side. He had epigastric pulsations. Apical impulse was noted on the left fifth intercostal space. There were no scars, sinuses, or dilated veins. Palpation, trachea was central. Apex bit present on the left fifth intercostal space, just outside the midclavicular line. Diffuse, occupying more than one intercostal space. RV type with lateral retraction. Left parasternal lift was present in left fourth and fifth intercostal space. Parasternal lift is coinciding with the apical impulse. There was a palpable second heart sound at the right second intercostal space. No palpable thrill.
What are those epigastric pulsations?
Sir, epigastric pulsations are like below
These
the
are because of
RV type
what?
of.
One you said RV type.
Yes, sir.
What else you can feel over there?
So any pulsatile mass from the aorta will also present with epigastric pulsations, or any pulsatile mass in the liver will also present with epigastric pulsations.
Okay, so on palpation, how will you differentiate between these?
So if we place the index finger below the xiphisternum, any mass from aorta or pulsatile mass from aorta will touch the pulp of the finger, and the RV will touch the tip of the finger.
And you feel this is because of
RV.
RV.
Enlarged.
Okay, okay. Go ahead.
So auscultation, S1 is audible, normal. S2 is single, best heart at the apex. There's no inspiratory or expiratory split, audible with plain stethoscope. S2 is louder than S1 at apex. There's a constant ejection click, best heart over right second intercostal space, parasternally. Also, it's hard over left second intercostal space, and also at apex. There's a continuous murmur, grade 3 by 6, hard in both right and left subclavicular regions, at left infraxillary region, and over left infrascapular region. There is also a grade 2 by 6 ejection systolic murmur, hard in right second parasternal region. The murmur reduces in intensity with squatting and isometric hand grip.
So there are two murmurs?
Yes, sir. One is continuous.
And which is because of?
Probably because of collaterals.
Collaterals.
Yes.
And the second murmur is grade 2 by 6, you said?
Grade 2 by 6 ejection systolic murmur, hard in right intercostal space. That is probably because of flow murmur through a dilated aorta.
Okay.
Per abdominal examination, liver is palpable on the right hypochondriac region, mildly enlarged 1 centimeter below right costal margin. It's non-tender, non-pulsatile. The tympanic note is noted in the left hypochondrium. There is no splenomegaly. Central nervous system, higher mental function is within normal limits. Cranial nerve examination normal. Motor and sensory system normal. Cerebral signs normal. Respiratory system, trachea was central, bilateral, normal, vesicular breathing. So my provisional diagnosis is cyanotic congenital heart disease, cytosolitis levocardia with decreased pulmonary blood flow, tetralogy of phallophysiology with aortopulmonary collaterals. There's no feature of infective endocarditis with elevated JVP in a patient with dysmorphic faces, the patient being in sinus rhythm with functional class NYHA2.
What is NYHA classification and what it tells you?
So NYHA is in a patient with known cardiac disease. If the symptoms of chest pain, palpitation, dyspnea, and syncope are present in the following categories: 1, 2, 3, 4. One is no symptoms at in ordinary activity. 2 is restriction of ordinary activity. The patient has the following 4 symptoms while doing normal ordinary activity. 3 is the patient has the following symptoms in less than ordinary activity, and 4 is the patient is symptomatic at rest.
Just go back to your findings.
Yes, sir.
Dr. Rama, Dr. Mandal, Dr. Tiwari.
Sir, I just want to point out, like, Devdutta is a pretty good presentation, very elaborate. You have presented quite a lot of things, but I would like to point out, for the sake of others, I would like to point out a few small little things, like, so go to a JVP, for example. You said it's elevated, your JVP is elevated. Then if the JVP is elevated, should you be doing a hepatojugular reflex?
No, sir. Sorry, sir. That is a.
So these are very small and important points, right?
Yes, sir.
Okay, that's number 1. So number 2, your left parasternal heave, you didn't grade it, like.
What is the grade?
So it is a lift because it is palpable less than 50% of systole. If it was palpable for more than 50%, then I would compress it with the palm of my hand to see if it is abolishable. And if it was abolishable, then that is grade 2, and not abolishable is grade 3.
It's better you should have told this is grade 1 heave.
You say grade 1, right? Commit at the outset that this is grade 1 left parasternal heave or impulse, whatever, right?
Okay.
So, what is the S2 like? S2 is like, is it A2 or P2 or fusion of A2 P2?
Sir, I can't hear you actually.
What is?
No, is it A2 or P2 or a fusion of A2 P2?
Sir, from my total examination, I have a possibility that this is A2.
But you never said the A2 is loud, like, because you said A2 is palpable in your second area.
Second area, yes, sir.
But you never said that A2 is loud, like.
So since S2 is single and it is louder than S1 at apex and it's audible at apex, and we are not dealing with an ASD Eisenmenger, so probably this is A2.
Very good. So basically, it's better to commit that whatever sound you are hearing is louder. So
yes,
you will be immediately asked, how do you know? So how do you generally grade A2 P2 loudness?
Sir, P2 is said to be loud if it is equal to A2 at left second left parasternal region. If it is more than A2, then we will find a heave in second grade 3 heave.
And did you find any pulsation there? Because aorta is dilated, it seems to be producing a clicker, so producing a loud sound also. Are you able to feel a aortic dilatation anywhere?
Sir,
are there any suprasternal pulsations or anywhere?
No, sir. There is a palpable A2 in the right second intercostal space, but there is no other pulsation.
So now come to your diagnosis, like.
One question, Rama, if I can ask.
Yes, sure.
Small, just go forward, Devrata. Just go forward. एक और चलो आगे. एक और, yeah. Percussion, do you think percussion is important in this? Maybe I missed it, I'm sorry. But did you tell about percussion?
Sir, I didn't do cardiac percussion because there's a possibility of only clots being dislodged.
No. Sorry. Possibility of?
Sir, I didn't do cardiac percussion.
कोई बात नहीं. Just go back a minute because your presentation looks solid. But पीछे जाओ एक और. Because जैसे डॉक्टर रामा बोल रहे थे अभी, you write a palpable second heart sound at the right second intercostal space. So normally in a tetralogy physiology, you don't really expect any palpable sort of a sound or anything. You might feel an impulse somewhere. So that is why percussion is very important in this case, because you have to say the second intercostal space on the left side is resonant or dull. So that is the main thing, right? Because you want to comment about the pulmonary artery being dilated or not being dilated. You are expecting the pulmonary artery to be posterior. There is no P2. There is a single S2. What do you think, Dr. Rama?
Yeah, agreed, sir. I think possibly if at all percussion has any role in this kind of case only, it will be having some role. So the other routine cases, we may skip percussion, but it can tell you about situs here, the other things here. So this may be done in this case, like.
Also,
but one more thing. Yeah, so Dr. Mandal, go on, sir.
Dr. Mandal also will get that second sound, palpable sound in the second intercostal space.
Yeah.
So one small point is that there is no thrill is good enough. You don't have to say no palpable thrill.
No thrill. Yeah.
The thrill is always a palpable this only.
Okay.
You can say no thrill. So then go on. Like one more thing is that ejection systolic murmur could have been better described. Like,
okay, sir.
Is it functional thing or is it an organic murmur? There is a stenosis there.
It appears to be a flow murmur, functional murmur.
So how are you conveying that to us? So for example, sir, you've done dynamic auscultation, but you're not describing the murmur in full.
Yes, sir. So
what is the description that you want to add?
Sir, it is radiating to the right carotid, and
what is the pitch of the murmur? What is the duration of the murmur? And what is the most important thing? Like for the sake of every student, whenever you write, like for example, some things are very important in each murmur. Like, so the most important characteristic in the ESM is peaking of the murmur. So peaking of the murmur. Is it early peaking, mid peaking, or late peaking? So that gives you the maximum information as a cardiologist. So now describe again your ejection systolic murmur.
So this is a grade 2/6 ejection systolic murmur. It starts off with the constant ejection click, and it is early peaking, peaks early in systole. Then It is a decrescendo murmur and ends.
Can you get a decrescendo murmur? Yes, sir.
What does a decrescendo murmur tell you?
So it's a crescendo, decrescendo, like it's a diamond-shaped murmur, kite-shaped murmur. So go on, go on.
Decrescendo murmur says that
kite-shaped murmur होगी ना ये. Crescendo, decrescendo.
Okay, go on, go on.
Better to say diamond-shaped murmur.
Diamond-shaped, yeah. Go on, go on.
Kite-shaped you will get in pulmonary stenosis.
Go on.
Sir, so this is the per abdominal examination.
No, like the murmur description.
Yes, sir. So it
What
is
is the picture of the murmur? You have not committed the picture of the murmur. What is the usual picture of an ejection systolic murmur? Because ESM is a very common murmur across cardiology clinical auscultation. Like.
Yes, sir. So if if this is S1 and this is the click.
No, fine. I'm asking about the pitch of the murmur. What is the pitch of the murmur?
Pitch.
Yeah.
Sir,
low pitch, high pitch.
Low pitch, high pitch. Typical pitch of an ejection systolic murmur.
Sir, typically, if it's organic, it's high pitched, but
no. So, what is the typical high pitch murmur that you get in cardiology?
Sir, the murmur of aortic stenosis. And
no, aortic regurgitation is a high pitch murmur. Low pitch murmur characteristic example is mitral stenosis. So, roughness and pitch you don't confuse. So, what is the pitch of the murmur indicates? It indicates the frequency of sound.
Yes.
So the female voice is a high pitch sound and the male voice is a low pitch sound, rough and sound. So don't confuse pitch with harshness and other things like.
Right.
Okay, go on.
So this patient has cyanosis, no? You said.
Yes. Yes.
So just quickly, can you tell me if the patient is cyanosed, he has got arterial desaturation or he is hypoxemic? What are the cutoffs of the oxygen saturation? Clinical cyanosis is evident at a saturation of less than?
So 85%.
Excellent. And hypoxemia?
And in hypoxemia?
90. Okay. And arterial desaturation? कैथ करते हैं ना, हम कहते हैं कि arterial desaturation है, तो it is less than? Usually less than 95, right? So 95, 90 and 85, arterial desaturation, hypoxemia, cyanosis, right? Okay, go ahead.
And
go to your diagnosis now. Sir, go on, sir.
Yes. Why Dr. Ramakrishnan emphasizing on the peaking of the murmur? What it tells you?
Sir, for
what
the
it indicates hemodynamically.
Yes, sir. Sir, a murmur peaks. When the pressures, the pressure difference between LV side and aortic side. So if the systolic murmur, it peaks when
you are right.
Diastolic pressure on the aortic side. So
for example, I'm just trying to help you. Suppose what will happen if mild AS is there and what will happen if it is severe AS is there in terms of peaking?
Sir, if it is a severe AS, there will be late peaking because the LVEDP for the
not talk about LVEDP because it's systolic, ejection systolic murmur you're talking about.
For the systolic pressure on the yes, sir. For the crossover of pressures, it will take a long time for the
long time to eject.
Ejection time will be.
Go to your diagnosis.
So while you're going to diagnosis, one small announcement: if the PGs can post their questions online, so we can have the benefit of both the examiners answering those questions if we have the time. So please post your questions, queries online. Go ahead, Devrata. You're doing really well.
You are doing really well. Most of the questions are being asked to make others understand a bit more, and common garden questions are being asked and then answered. You're doing very well. So what are the things that you would like to change? Anybody can post right now. We will not tell what are the changes to be done. I would request all the PGs to post better way of giving this diagnosis. Like, what are the differential diagnoses you want to keep at this stage?
The differential diagnosis at this stage is tetralogy of allophysiology with decreased pulmonary blood flow and with major aortopulmonary collaterals. So since the collaterals are huge enough to cause continuous murmur, so this might be a case of VSD with pulmonary atresia. Apart from that,
keep this slide on your diagnosis, please.
So why not pulmonary atresia as your first diagnosis, like in this case?
Pulmonary atresia with intact, only isolated pulmonary atresia.
No, VSD pulmonary atresia as your first diagnosis.
Why is it not?
I did not put up a definite diagnosis of VSD pulmonary atresia over here because I would be requiring clinical means ECG and echo for the final diagnosis.
So, like from clinical standpoint, what is the most important point that you should make in this case? Consider VSD pulmonary atresia as your first diagnosis. Is there any RVOT murmur you are hearing here?
No, there is no RVOT murmur. Absolutely none.
You are not getting a RVOT murmur and you are getting multiple collateral murmurs. Then that should make your diagnosis pulmonary atresia, VSD pulmonary atresia.
Yes, sir.
As your first diagnosis.
Yes, sir.
So for that, in history, you never elaborated on whether he was evaluated somewhere. Was he told he was inoperable or was he told he was operable? They did not undergo surgery because of financial reason and so on and so forth. Like any such history available?
Sir, he did not like approach any physician for that.
Okay.
Basically, he was told that it will be a very complex surgery. So he went on from door to door to ask for more medications so that his symptoms could be relieved.
So now nobody is putting up a better diagnosis. So I think I agree that I suppose that all of them think that this is the best way to put your diagnosis. But I would suggest a few changes. That what is this elevated JVP? Do you think that patient is in heart failure or not in congestive heart failure?
Sir, since the patient is has survived for a long time and he's 31 years old, probably he has developed RV diastolic dysfunction and with high.
So we never put a diagnosis of elevated JVP as a final diagnosis.
You're right.
Heart failure or not?
We always write whether patient has heart failure or not heart failure. Never put elevated JVP as a diagnosis.
How common?
What do you think the patient has heart failure? No heart failure.
How common is to have raised JVP in tetralogy? Classical, not maybe in this patient.
Sir,
common, uncommon, unusual.
For adult patients, it is quite common. But for infants or children, it is quite uncommon. Like adults.
For the sake of everybody, this is a very common problem that happens. If your mean JVP is elevated, you always call it heart failure. But if your JVP only the wave is elevated, for example, A wave is very prominent, is very large, but the mean JVP columns are not elevated, then you don't call it as heart failure. So you can have a patient with other features are not there, but just elevated JVP, definite elevation of mean JVP, you should always call it heart failure from clinical standpoint.
So quickly, can you just tell us what are causes of heart failure in tetralogy? One is you said adult tetralogy, right? Because of RV dysfunction. Anything else?
Anemia,
yes.
restrictive VSD, then aortic regurgitation, pulmonary regurgitation, tricuspid regurgitation, then collaterals like MAPCAs,
Excellent.
LV dysfunction,
Great. Okay.
surgically created shunts.
So why do they develop dyspnea class 2 like VSD-PS physiology, right-sided obstructive lesions? So why do they develop dyspnea in first place?
So because of cyanosis, so because of severe cyanosis, the sign H plus ions, they stimulate the respiratory center. The PCO2 stimulate the respiratory center, and the patients develop respiratory muscle fatigue as well as skeletal muscle fatigue.
For example, sometimes a patient with PS also has this symptom of dyspnea. IPH also has the symptom of dyspnea. So how do these right sided lesions have dyspnea? Apart from cyanosis, if they are cyanosis, it's okay. Cyanosis may worsen with exertion, and then they can produce more dyspnea-like sensation.
If the right-sided lesion can also have venous obstruction, as in TAPVC or obstructive TAPVC, so they can present with dyspnea as well.
Like, for example, what is the cause of dyspnea in an IPH, for example, idiopathic pulmonary hypertension? So
idiopathic pulmonary arterial hypertension, the J receptors of pulmonary J receptors are stimulated, and that cause the sensation of dyspnea.
That is one hypothesis. So, what are the other important hypotheses like? They are not able to raise the cardiac output with the demand of exercise increases. Yes, so the fixed cardiac output, the cardiac output may not increase. At rest, they may not have low cardiac output. They may not be able to increase the with exercise. They cannot increase, and then the ventilatory muscle fatigue. Then at times some other physiologies can have ventilation perfusion mismatch, and all those things are various reasons for dyspnea in right heart failure, right side lesions primarily. So any other differential diagnosis you want to keep, like for example, other physiologies, or when do you diagnose in a TOF-like physiology, when do you consider from clinical examination other physiologies, like DUR, VSD-PS, tricuspid atresia, VSD-PS, those kind of a thing, when do you consider clinically from clinical examination wise?
So clinically, I would have diagnosed DORV if there was a long pansystolic murmur at the lower left sternal border, and along with that, I would have got.
Let's wait. So you are saying DORV, VSD-PS, the VSD is restrictive?
No, sir, but DORV, it's an obligatory.
Okay.
So there will be a murmur.
VSD, there won't be any murmur at VSD level. Why are you thinking that DORV, VSD-PS will have a restrictive VSD murmur?
It's a large non-restrictive VSD even in DORV, no?
So you will never get a VSD murmur unless there is a restrictive VSD.
अगर आप DORV की, you imagine the physiology, the LV and the RV pressures are identical. So you're right, there is an obligatory shunt. There is obligatory VSD because that is the only source for the LV to eject. But the pressures are equal, no?
So that is not the thing. So what are the conditions that are associated with the LV apex? Like for example, VSD-PS physiology that have LV apex.
So tricuspid atresia, VSD-PS, DORV, VSD-PS.
DORV, VSD-PS, double outlet. Why should it have a predominant LV? When does it have a predominant LV?
So with the
both the arteries are arising from RV. RV has to be dominant. So RV will be apical forming generally.
So with the restrictive VSD, LV will be dominant.
That's very good, but that is extremely rare. That should come very lower down in your order. Okay, good. Very good.
Tricuspid atresia and one more. Single ventricle, na? Univentricle.
LV morphology.
Any other cyanotic inguinal artery which is not VSD-PS physiology that can have LV apex?
Sorry,
Very good. Very good.
Epstein.
Then one more.
Excellent.
Just to complete the list for everybody's sake.
So mitral atresia. No, sir. Epstein.
Intact septum with pulmonary atresia.
AIBS.
So that one of the other ways to diagnose these physiologies will be from LV apex or RV apex. That's number one. So what are the other ways to differentiate? Like how to diagnose CCTGA clinically, CCTGA character transposition clinically?
So there will be pulsation of the aorta in the left second intercostal space.
Very good. So if there can be a
Excellent.
pulsation or a palpable P2 or a palpable aortic sound or a very loud sound there, then you start thinking of a CCTGA. And one more clinical situation where you start thinking of CCTGA will be when there is a mismatch between situs and the cardiac position. So that is one situation where CCTGA comes up higher up the order. So how do you diagnose DUR VSDPS clinically? So somebody is asking that, I'm asking you the same question.
How to differentiate top from DOR? The chat box पे भी है, some doctor from Hyderabad, Dr. Saru. How do you differentiate?
The murmur, there will be murmur of ejection systolic murmur of pulmonary stenosis, and it will be 1 or 2 spaces higher, since in DRV it's generally a valvular PS, and also there will be pansystolic murmur of maybe.
To answer this question, so for want of time, I will take this question and answer it. So it's very, very difficult to differentiate DRV VSDPS and tetralogy if it is normally related. Both are nearly the same physiologies. Like it's almost impossible to differentiate. But if it is really malposed results or a transposed like a physiology, like where the aorta is right and anterior and all those situations, there can be a problem. Like there, the proportion of cyanosis and the degree of the murmur may not correlate inversely as in tetralogy.
So normally,
what is the relationship between cyanosis and the murmur in tetralogy?
It's inversely related.
So sometimes you may find a patient who is very blue, but you find a very good loud murmur.
So this is an excellent thing which sir is making, murmur out of proportion to intensity of cyanosis in a VSD physiology. One is DORV. Second is if it's a AV valve regurg. AVSD with PS, AV valve regurg. So one is DORV, murmur out of proportion, or it's a AV valve regurg, as happens in congenital corrected TGA, left-sided Epstein valve regurg, or a AVSD with PS. So these are the 2-3 situations.
So I think you just complete the list that I was asking. One is so how do you differentiate other physiologies in a VSD PS physiology? Number one is LV apex. That's a very strong point. Then you have the CCTGA features that are there, or you can think of murmur disproportionate to cyanosis, or you should think of AV regurgitation, presence of AV regurgitation. So presence of AV regurgitation will immediately point towards what diagnosis, Devdutta? If you find a murmur of left or right AV regurgitation.
AV canal defect with
very good.
PS.
AV SDPS, then what else?
One more.
So commonly CCTJ VSDPS, sir has just pointed out, and then one more thing will be single ventricle PS also have, some of them can have a lot of AV regurgitation by this age.
Which is, Dr. Rama, is very unusual for single ventricle.
You have to think of fallot tetralogy also.
Yeah. So if Dr. Mandal and Dr. Rama permit, can we go to X-ray and ECG?
Just one more classical tick mark wala question. One more thing, sir. How do you differentiate the classical intact septum PS with from VSD with PS?
Intact septum PS will have a prominent A wave from clinically. And,
clinically.
Yes. And if he or she goes into RV failure, she can have a V wave as well. Then from examination point, there will be cardiomegaly, then parasternal heave, then RVS3 or RVS4
parasternal
will
be like grade 2 by or grade 3 by 3 parasternal heave.
Right.
Intact septum. Yeah, good.
Then RVS3 or RVS will be there.
Excellent.
And so the murmur, it is directly proportional to the amount of stenosis. More the stenosis, more.
Very good. Very good. So these questions are asked whether you understand the hemodynamics of intact septum, how the things change with the intact septum and the VSD.
And for everybody who's listening, this is the exact way in which you should answer. The way she has done: JVP, inspection, palpation, auscultation. Very nice.
So I have nothing to add, so you can go on, sir, if others are okay.
Dr. Mandal sir, X-ray, ECG, Dr. Tiwari sir.
Dr. Ankit, you want to ask anything?
Very nice.
Dr. Mandal,
Okay.
you want to add anything?
Okay. Go
I
to
think we
X-ray.
go ahead. Go ahead. I think
Good
she
job.
has done
Good job. She's
nicely
done.
done.
She's
Yes.
done.
X-ray or ECG, which one you like to prefer?
Devrata, you will be
To-
doing it or somebody else is doing it?
Sir, my colleague Dr. Shuman Ghosh will be presenting X-rays.
Okay.
Thank you,
You may have
Devrata.
to stop sharing maybe.
Yes, sir. I've stopped.
So thank you, Devrata. Good evening, respected teachers. So, am I audible, sir?
Yeah, audible.
Yes.
Yes, sir. So, sir, this is 12-lead ECG of the patient with standardization and sinus rhythm. The rate is around 72 beats per minute, and there is right axis deviation of around plus 110 degrees, and there is clockwise lobe and incomplete right bundle bunch block with features of right ventricular hypertrophy with strain pattern, and there is a sudden transition of QRS to small r capital S pattern is seen in V2 from V1, and there is.
Why you said bundle branch block? Left one.
Sir, RVV, incomplete RVV is and there is a borderline prolonged pair and tall peak P waves.
Fits in with your diagnosis.
Sorry, sir.
Macaro fits in with your diagnosis. Where is the transition? Did you set the transition?
Yes, sir. It may be due to the window effect of the VSD.
Early transition, late transition.
Sir, it is early transition.
So, Dr. Ghosh, you are also a senior resident, final year resident?
Yes, sir.
Okay. So, I just want to make sure that you are not an assistant professor or anything. I should not be asking question or not. Okay. So, why do you say this is RVH like, first of all?
So, in the background of RVH, it's difficult to comment on RVH, but there is suggestive evidence of the axis that is plus 110 degrees. And also there is predominant S wave with the lateral leads. And
so what about the R dash? How much R dash should be there? Suppose what is the criteria to say RVH? Tall R should be there. What is the criteria to diagnose RVH?
Sir, if there is complete RVV, then 15 small square should be there per dash. And in incomplete RVV, there should be at least 10 small square.
But what about your B3R and B4R? You're not focusing on them, like.
Sir, actually, I have taken that lead to show.
Very good. You should take in such a case. You should definitely take it. But what is your interpretation of that?
Sir,
will that add to your diagnosis of RVH?
Sorry, sir.
Does it help?
Does it help you in diagnosing RVH in this case?
Yes, sir.
And why do you get a sudden transition here?
So
why
there
is a sudden transition in tetralogy?
So because of the window effect of the non-restrictive VSD that occurs in top, there is sudden transition from V1 to V2.
But what is unusual in this ECG? Like a typical tetralogy ECG, what is unusual for this ECG?
So first of all, the PR interval is prolonged.
So that
and also there is
okay. Anything else?
Also, and there is a TO inversion that is from V1 up to V5. That is not generally seen unless there is suprasystemic RV pressure.
So definitely that's not RV. There is early transition. Most of them is transitioning into LV. But then there is quite a bit of ST depression and as well as T wave inversion till V5, V6. That is quite unusual. Like
this right-sided strain is very unusual. That's what Dr. Rama is trying to say. RV strain you usually don't get. And as you rightly said, seen with suprasystemic RV pressures. So that is a bit unusual.
Go on.
Go on.
Can you move on to X-ray, sir?
Yes, sir. So this is chest X-ray of the patient, PFU with proper exposure and no rotation, and held in end inspiration, showing abdominal and bronchial sided solitus, and livocardia, and the apex is of RB type. There is borderline cardiomegaly is present. The cardiothoracic ratio I measured that came to be 58%, and the arch is left-sided and prominent aortic knuckle. The pulmonary bay is concave with reticular and or lacy pattern of vascular markings, which is distributed unevenly in the lung fields, along the lung fields. The right lung field, as you can see, has well visualized vascular markings, whereas the left lower lung field has grossly decreased vascular marking. So there is discrepancy or asymmetry between the vascular pattern between the two lung fields. And the lateral view also shows some degree of right ventricular enlargement.
So Dr. Ghosh, your X-ray description is reasonably okay. You have pointed out all the positive points, but I would suggest that all of you should go in a systematic fashion in X-ray. So you start with situs. So what is the situs here?
So the situs solidus, sir. Because
How do you
fundic
say
acid
that
is seen
situs
on the-
solidus?
So fundic acid is seen on the left side, and hepatic shadow on the right side.
And what is bronchial situs?
And so regarding the bronchial situs, the right bronchus is more vertical and shorter than the left, which is more angulated and longer than the right.
And then you mentioned about cardiomegaly. What about the other cardiac chamber enlargements like?
So there is RV enlargement, but RA enlargement does not make the full criteria. So there is only RV enlargement.
Any other enlargement that you can find out in this X-ray? Can you trace the marker, get a marker in the X-ray and then trace your ascending aorta? Is the ascending aorta prominent?
That is prominent.
Yes, the ascending aorta is prominent, sir.
So that you
Sir,
should have marked then. And you can see a calcification in your, just below the knuckle, there is some calcification is seen. So why are you saying this is RV apex or RV is enlarged?
So because the left cardiophrenic angle is more acute and there is upturned apex. So
then once you are finished with all this, then you go to the lung fields, lung vasculature. What is the most important thing? The first immediate concern should be your description of three things. One is your pulmonary blood flow, your PVH and your pH. All these things should be immediately mentioned. Before you go into these, you're very good. You have mentioned all these reticular lacing and all those things. What is the importance in this case?
So because there is asymmetry in terms of vascular.
So what does this kind of reticular lacing pattern of vascularity suggest to you?
What is it?
What does it suggest on X-ray?
So it means the lung segment is perfused by MAPCAS. And
very good.
Collateral.
So this is a very classical
Collateral.
feature where you can find these segments are supplied by MAPCAS most likely. But before going into that, you should mention about QP, PVH and pH. What about your QP? Is it what is the pulmonary blood flow here? Is it reduced or normal or increased?
So actually there is asymmetry in the right side. Apparently there is increased blood flow.
So both are reduced. Both are actually reduced. You are not even seeing the central PAs in both the sides. Both are reduced, but whereas you're not getting any end-on vessel at all.
Yeah.
It seems more reduced on the left side as compared to the right side. But most of the things are fine collateral-based fillings only you are able to see. Once you see this pattern, what immediate next attention should be to? Is there any rib notching?
Rib notching, yes. Are you able to see? We can't see from here.
I think we can't see anything, sir.
Can't see.
But what about one more important thing you didn't mention is the arch, like which sided arch is this?
Sir,
right
I mentioned, sir, it's left-sided arch.
Sir.
You mentioned.
Okay, I missed it. Sorry.
Yes.
So as you know,
what about
Dr. Rama is pointing out. Sorry, go ahead. No. Complete.
Kyphoscoliosis part.
Yes, there is scoliosis.
Lateral में दिख रहा है.
So you start with this, all these things, and before. Sorry, you can go on.
No. Just to summarize what he is telling you, just go in an orderly manner, and 3 things in the lung field which he says. In differential vascularity, you might want to mention. No, there appears slightly blacker on the left side, and notching you should always commit whether it's seen or not seen. You will obviously see inferior rib notching in these cases. So again, you can go home and revise all the students, causes of rib notching, superior, inferior, both superior and inferior, which is seen in hyperpara, etc. So these causes are important.
So somebody is asking, say, any criteria for differentiating increase and reduced blood flow on X-ray? So what is the criteria for increased pulmonary blood flow, Dr. Ghosh?
Sir, actually, if we can part the lung field into 3 parts, generally in the distal third there is very less blood flow, but some blood vessel can be seen. But in case of decreased blood flow, it is not seen actually at all. And in case of increased blood flow, the distal third, distal outmost third, there the part will be containing the blood vessels.
That is one part. So, but somebody can develop some part of pH, then that thing can reduce over time. For example, a VSD pH or something else, the pH may reduce the distal 1/3 blood flow. Still can have increased QP. So, what is the most important criteria for increased pulmonary blood flow?
Sir, end-on vessels is also important.
Very good. Very good. So, how many end-on vessels? How do you identify those end-on vessels?
So, those will be like circle.
So, yeah, one circle like vascular circle, dot-like circle. But how do you know that is enlarged? Because that will be there in normal vessel also will be sent.
5 to 6 generally is the cutoff. So, it is more than 5 to 6.
three on either side and more than 5 on both the lung field is generally considered criteria for increased pulmonary blood flow. How do you identify that as an enlarged vessel? Enlarged end-on vessel is if it is larger than the accompanying bronchus.
Bronchus, yes.
Segmental bronchus, whatever it is accompanying, if it is larger than that, we call it that way. So most of the increased pulmonary blood flow will have increased larger pulmonary artery also. That means RDPA will be dilated. The pulmonary artery may be prominent. So these are the 3 features that we'll find. Most important feature is an enlarged vessel, an end-on vessel that is larger than usual. 3 on either side or more than 5 is generally considered increased QP. So what is the inference from this X-ray?
So inference is there is some the arch is left-sided and there is RV type of apex and there is uneven blood supply to the lung fields, most likely which is due to the systemic collaterals because of the collaterals, and the pulmonary blood flow is reduced.
So is it consistent with your diagnosis? Most likely we are dealing with a pulmonary atresia situation.
Atresia. Yes, sir.
Because such differentials, these things are generally common. Or very rarely you can find it in top with LPA atresia or something like that.
So on the echo, you would specifically look for this, right? Absent LPA or LPA atresia.
And confluence.
Yes. You have the echo also?
Yes, sir.
Devdatta, before you go into echo, so I just want to clarify from Devdatta whether there were many murmurs in the back and over the scapula or in the shoulders or in the back.
She told that there are murmurs.
Yes, sir. There were continuous murmurs.
Okay.
So can I move on to echo?
Yeah, please.
Subcostal view that confirms the abdominal visceral situs. And IVC seem to be draining to a chamber that is morphological RA. So the other one is morphological LA separated by IS. And RA is connected to a chamber having 4 straviculations and whose AV valve has got septal attachment and is more apically displaced than the other. So it is morphological RV. And so the other one is LV. So AV concordance is maintained. And as you can see, RV hypertrophy is there. In subcostal coronal view, the aorta is seen to be arising from both the ventricles. And a malaligned VSD is also seen. And a small 7.4 millimeter waist ASD is also seen with right to left flow. And this is subcostal sagittal view. showing a non-restrictive subaortic VSD, and no great vessel has emerged from RVOT. And continuous wave Doppler across the RVOT has failed to demonstrate the same. This is parasternal long axis view, showing a large non-restrictive VSD with bidirectional flow and overriding of aorta of almost 50%. Now, aortomitral continuity is present, and LA and LV is not that much underfit. And continuous wave Doppler across the VSD, demonstrating the bidirectional flow. And the MO data shows LV function is preserved and there is dilated aortic root. Parasternal long axis view showing septal flattening and the subaortic VSD, and RVOT does not give rise to any great vessel. And continuous wave Doppler across the RVOT demonstrates no pulsatile flow across the RVOT. And an apical fourth chamber view showing dilated right atrium and mildly dilated RV, and mild tricuspid regurgitation is also there with the tear pressure gradient maximum 36 millimeter mercury. An apical five chamber view showing malaligned PSD, aortic overriding and mild aortic regurgitation. The jet is predominantly to the RV. And it shows the remote data along the lateral annulus, and it shows RV dysfunction as obtained by TAPSE of 1.4 centimeter and RVS prime of 4.65 centimeter per second. And this is suprasternal long axis view showing left-sided aortic arch with MAPCAS. The upper one could be a PDA because of the location, and the continuous flow one is demonstrated across the MAPCAS or PDAs.
I think excellent echo, but I would suggest that because maybe having a poor window also.
Yes, sir.
But I would suggest that whenever you do an echo recording anytime, you should do it with ECG. ECG should be there, like.
Okay, sir.
So, but were you able to see the confluent pulmonary arteries?
No, sir. No, sir. Should I move on to cath?
Yeah, yes. Go on.
So this is RV angiogram in lateral view with pictal catheter, shows opacification of only one great artery from which the coronaries are arising. So it is most likely the aorta, and it is dilated. And passage of dye to a posteriorly located chamber, which is left ventricle across the VSD. And this is the descending thoracic angiogram with pigtail in the AV view, confirms the left-sided aortic arch. One MAPCA is seen to be arising directly from aorta, but no PDA is seen. And delayed opacification of the vessels are seen in the vicinity of the left hilum. And the source is coming from above. So it mandates the next selective angiogram of the lima that shows the MAPCA from lima. And then selective angiogram of right subclavian artery was also done, and it shows the MAPCA arising from right subclavian artery draining into the right hilum. So this is all we have.
So where it is connected, Dr. Ghosh, these collaterals so called.
So this is connected to the hilum actually. As you can see, there is no filling of the branch pulmonary artery, and also there is no intrapulmonary ramification directly. So most likely it is connected to the hilum, at the hilum.
So what is the final diagnosis in this case?
So this is a case of cyanotic congenital heart disease with decreased pulmonary blood flow, situs solitus, levocardia, and with tetralogy fellow with pulmonary atresia with multiple indirect and multiple indirect MAPCAs with patient in congestive cardiac failure and NYHA class 2 at present, and no feature of infective endocarditis or immunodeficit at present.
But suppose when you give a final diagnosis, the other fellow reading the diagnosis should know the plan. But from this diagnosis, whatever you have given, so such a large diagnosis also, I don't know the plan. What is the most important thing that is missing?
So the pulmonary artery confluence should have been mentioned.
So there are no central pulmonary arteries, like there are no
Yes,
mediastinal
yes.
pulmonary arteries in this case. That should be prominently featuring, because that is a critical thing in decision making. Like,
Yes.
so that's number one. Number two is even though it's a very common practice in today's time to call it like a TOF with pulmonary atresia, if you go to the literature, there is no disease called TOF with pulmonary atresia. It's always VSD with pulmonary atresia. So TOF is TOF, and there is VSD pulmonary atresia. So it's better to use the
very
term in academic
important.
circles
Yes.
as the term VSD
Yeah.
pulmonary atresia rather than TOF pulmonary atresia.
Yeah.
That's for everybody's sake, that it's better to use the term VSD pulmonary atresia. So another thing is, you said there is a confusion about right heart failure in this case. So what was the RA pressure in this case? You have done an invasive angiogram.
Can you show the pressures and saturation if you have?
Sir, actually the patient got unstable while performing the cath. So we could not take the.
So any other investigation you could have done before cath or clarification?
So CT angiogram with 3D reconstruction would have been a better option.
So generally in most of the institutes, this no PAs generally are diagnosed more with CT angiograms rather than getting them to cath lab, because they are otherwise unstable. They are always borderline. You produce a vasovagal, you are in trouble. So
Yes.
it's better that they can undergo a CT angiogram if the PS are not seen at all on this thing. But what can you do now? Anything can be done now? What
So
will be your
actually,
plan now?
as the pulmonary arteries are not confluent, so we should be going for multiple stage repair. So first unifocalization is to be done, and then after performing neopulmonary artery.
So who can do unifocalization in a 31-year-old with no pulmonary arteries?
Yes, sir. It's very difficult.
So he is inoperable. You cannot do unifocalization at this age. You cannot do anything. So for unifocalization also, the surgeons want at least a thin thread like PS. They unfortunately, we are not gods. We cannot create the pulmonary artery arborization and put them together. So this fellow is practically inoperable.
Yeah.
No surgical options will be there. Maybe you can do a CT angiogram, demonstrate thin PA, then you can think of something.
You can do a CT to see if there is some thread which the surgeon can do something at least, because.
But anything else you can do, because he is so symptomatic. You are saying he is very symptomatic. Can you do something else?
That generally, if the patient is having hyperviscosity symptoms, then medical management by means of phlebotomy can be done.
So anything else, any other intervention therapy can you think of?
Intervention, sir is asking. Anything else which you can do to sort of palliate him?
Palliative him bit more.
We can put in a systemic to pulmonary shunt.
For that, what is needed, Dr. What is needed to put a shunt?
Confluence is needed.
Confluent pulmonary arteries are needed. Like at least a small pulmonary arteries are seen. Suppose you have a 5 millimeter PA in an adult also, they can put a 5 millimeter central shunt. So central shunt will be better in them. But if they don't have that also, this fellow doesn't seem to have a central PA at all. So in that case, what can be done?
So had the PDA been there as a collateral, then we would have been stenting the PDA. So
you can do a palliative stenting of the PDA or the collateral. MAPCA can be stented if there is a significant narrowing is there. But what is the downside of that?
Is there any downside if you open up that stenosis, put in a stent?
Yes, so there might be pulmonary vascular obstructive disease, or the stent related procedures like the stent thrombosis and stent.
Generally, these stents are larger stents. Generally, 5 mm, 6 mm stents are being put in an adult. Generally, the thrombosis and restenosis rates are pretty acceptable. But what is the most important concern? Like?
Then, sir, increased flow across the pulmonary circulation might.
So, what will happen? What will happen? Like, so they can have a segmental pulmonary edema, which can be really life-threatening in such a patient. So you do a stent because that is supplying one part of the lung. Like, so for example, if you look at the PDA here or the one large collateral here, that will be supplying the right upper lobe or right middle lobe or right lower lobe, or maybe at times two lobes together. So you open up that vessel with a 7 mm stent or 6 mm stent, suddenly there is a gush of blood and there can be localized pulmonary edema. That can be really, really life-threatening. Like, so that is the only thing that you can do for such a patient.
Nice. I think both of them presented really well.
Excellent, sir. They all presented. I think presenting in front of 300 people is no joke, sir. Like,
no joke.
So I can ask so many questions now, but I think of my residency time. I don't think I would have presented this well. Like,
yes, all compliments to both of you and to Dr. Mandal as well. Really, really good presentations. Really nice.
And they're very confidently answering also.
Yes. You know, as Dr. Rama said, to present live online. So and I'm glad that you guys came forward to do this because we need more volunteers. And thank you, Dr. Rama. Thank you, Dr. Mandal, Dr. Ankit, for sparing the time. So maybe Dr. Rama, if you permit, I mean, everything is discussed and there are some questions in the chat box. So can we request the Sunny or team to make a list of them, and then we can request Dr. Rama and Dr. Mandal to, at their leisure, they can just put in 2-line answers to them. Most of them were answered today, but there are a couple of questions which are still left. So
Sure. We will.
You can ask some final comments from Dr. Mandal and Dr. Ankit, sir.
Yeah, I'm going ahead and because Dr. Ankit, I think he was due to take a flight, so he has boarded.
Okay.
To me. And Dr. Mandal, sir, followed by Dr. Tiwari, sir, and then.
I think everything is discussed. In that, nothing left. Is very well discussed.
I think both the candidate has done a good job. What I am saying is congenital heart disease, it's like mathematics. So you have most of the residents who join the cardiology program, DM cardiology, they try to ignore this topic of very important cyanotic congenital heart disease. Out of the 16 congenital heart disease, if you see that, 4 you're not able to see is atresia, mitral atresia, because they don't come to you. So out of the 12, 70% are reduced pulmonary blood flow. And in the exam, you get a long case sometimes get a long case on reduced pulmonary blood flow. So if you focus on on this reduced pulmonary blood flow, so with differential diagnosis, so 6 diagnoses you make on differential diagnosis, Devrata. So like this, if you focus on this reduced cyanotic congenital heart disease, you'll understand the hemodynamics much better. Diagnosis is more clearer. And then certainly very small percentage complex congenital heart disease. This is by exclusion. Even at our level, sometimes it is very difficult to do it. That's what I want to say.
So one small thing, I think I was just going through the chat box. So most of the questions are answered. There was something about the pulmonary artery on the X-ray. So I just put up one photograph. Dr. Maitri from Kanpur, she says elevated JVP has to be re-examined. Dr. Rama mentioned about it. Dr. Rama, one last thing. Somebody has written, I think you did tell about this. Just in brief, you can just tell how to, if S2 is single, how to say it is A2 or P2. You did tell, but just can you just educate everybody once again?
I think Devdatta answered it very well. So I think let us make it very clear. Like the overall context of the case is very important. Putting them together with various other things is very important. And then the important thing is, where is it best heard? Where is it best heard? Whether it is heard best in the aortic area, the pulmonary area, are you suspecting some CCTJ like situation or not? So all those things are very important. And then most important thing is the overall clinical context of the case, where you think which is likely to be A2 or likely to be P2, likely to be a fusion of both. And then how is it heard in the apex? Like, these are the various ways by which you think of it.
And Dr. Rama, sorry, one more. Causes of early age Eisenmenger with cyanosis, you categorize them into 3 groups. So just briefly, if you can just once again.
So number one, the least common group is the most early group, that is CCHD increased QP. That is CCHD with increased pulmonary blood flow, that to become Eisenmenger. So they generally become Eisenmenger by around few months of age. Their cyanosis starts almost at birth. and they're all like the TGAs and then the other various other CCHD increased QP conditions that become Eisenmenger. Their survival is very rarely beyond 10 years, and most of them die by around 20 years of age. So that is the least common group. Second group is the insidious onset group, where they have nothing. They have no symptoms, nothing in their childhood, and suddenly they come with symptoms of exercise limitation and cyanosis coming in the adolescent age group by maybe around mostly in the second decade of life. That is roughly around 40-50% of all Eisenmengers coming to us. So the reason for that group to present like this is that either the parents don't remember the history of increased QP during childhood, or they could have gone through what is known as non-regression of pulmonary hypertension during infancy. Like in the neonatal pulmonary artery pressures, PVRI are never decreased. So they never go through that increased QP situation. So that is the explanation for that, hemodynamic explanation for that. The classical, the prototype that we always think is the one that is the third one that I'm describing is the most common, roughly around 60% of them. So they have a classical cycle, increased QP-like features, failure to thrive in infancy. But by the time PVRI increases, their flow, the pulmonary blood flow reduces. They have a quiescent period. They grow well, reasonably well. They are almost comparable to peers. But by the time they come to adolescence, they start having exercise limitation and onset of cyanosis. So that is the prototype we always think that adult Eisenmengers are like.
Excellent. Right. So I hope it's clear to everybody. So I think, Dr. Tiwari, we can close the session now.
Yeah, I think, yes, please.
And so from my side, at least, I'll thank all the examiners again very, very profusely for sparing nearly 2 hours. Thank you to both all the 4 examiners. In fact, thank you, Dr. Tiwari. Thank you both the students, brilliant performance, and thank you for all the students who have been attending online. And thank you to the entire Ajanta team. So you guys can take over now, please.
Thank you, sir. Thanks a lot. Now I would invite our marketing lead, Mr. Sunny Jaiswal, to say final vote of thanks.
Thanks a lot, sir. So very good evening to all the respected doctors. On behalf of Ajanta Pharma, I am Sunny Jaiswal, marketing head. Take this opportunity to put formal vote of thanks on record for making our today's second DMPG Ajanta Cardio Master Workshop a grand success. Would like to thank our today's case presenter speaker, Dr. Devdatta Das and Dr. Suman Ghosh for the insightful presentation. Special thanks to our esteemed course director, Dr. Aditya Kapoor sir and Dr. Satyendra Tiwari sir for all the guidance. Would like to also acknowledge the contribution of our today's eminent expert panelists, who is Dr. S. Ramakrishnan sir, Dr. Ankit Sahu sir, Dr. S.C. Mandal sir, and Dr. Radhakrishnan sir. Also, thanks to all DM and DNB PG participants for investing time in learning from the stalwarts of the cardiology. We encourage all the participants for the active participation in our future workshops as well. Please do not forget to log in for our third Cardio Master workshop dated 27th May, which is on the Saturday, and on the same time, which is 7:30 p.m. So with this, we conclude our today's second DMPG Ajanta Cardio Master workshop. Thanks to one and all. Good evening, and I wish you a very happy weekend ahead.
Thank you. Thank you, Dr. Rama. Thank you, everybody.
Thank you, Dr. Rama. Lovely.
Thank you, sir. Thank you. Thank you,
Yeah,
Dr. Mandal,
it
sir.
is worth listening your discussion. It's pleasure.
Thank you, sir. Thank you, sir.
Bye.